Hello, and welcome to today's health webinar. This episode is brought to you by our friends at DaVita. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Kamal Mangrajani.
Great. Thank you so much for that introduction. We're so excited to be here today for this health webinar on the adherence revolution, turning patients into partners. I'm so excited to be joined by our esteemed panelists. I'd like to invite them to introduce themselves one by one, perhaps starting with Kelly, and then Risa, and then Michael.
Thank you so much, and thank you to DaVita for hosting this important conversation today. My name is Kelly Franklin. I'm a senior executive with Oliver Wyman in innovation. I've spent my entire career in innovation and transformation consulting. A little over 10 years ago, I ended up having a patient experience, and after I got through that, I've spent a lot of my time doing keynote engagements and webinars like this to help hopefully improve the patient experience. So very pleased to be here.
Thanks, Kamal. I'm Risa Weisberg. I'm a clinical psychologist and a professor of psychiatry at Boston University. I spent most of my career in academic medicine studying the integration of behavioral health and mental health into medical settings and collaborative types of care for individuals with chronic illness. And then more recently, have been working to build, design, and test digital health interventions in some of those areas as well.
Great, thanks. Michael.
Hi, Kamal. I'm Michael Moustakakis. I'm a nephrologist from Hartford, Connecticut, where I've been a practicing nephrologist for over 25 years. I've had a lot of roles in my community healthcare system, but my clinical interests include shared decision-making, patients' rights, and end-of-life care. At DaVita, I joined DaVita 5 years ago, and I serve as the National Group Medical Director, where I help drive clinical initiatives. I'm support for our leadership team, our operations team, and most importantly, our physician partners providing care across the country in our clinics. And I'm so excited to be here to talk about this topic, which is really important to me because having seen decades of dialysis patients and late-stage chronic kidney disease patients struggle with these issues, it gets very personal very quickly. And it got very personal for me when my own father was on dialysis at the end of his life. So it really means a lot. And I thank you all for being here to share your perspectives.
Yeah, it seems like you have a lot of insight, both as a provider, as somebody who's actually worked to provide dialysis, and now as a caregiver, actually seeing that patient journey with your father. So really excited to get into it. Briefly, I'm Kamal Mangrajani. I'm a physician. I take care of patients with cancer and blood diseases, and I previously served at the Cancer Moonshot as the Assistant Director for Cancer Innovation, as well as on the Health Outcomes team at the White House. As the Assistant Director for Public Health. And so we did a lot of work focused on care navigation and patient engagement. So this is something near and dear to my heart and something for which we've actually developed policy solutions. But of course, there's always more to learn. There's always more for us to do. And we really want to center and focus our discussion on what that patient experience is like. So to start us off, Kelly, could you tell us a little bit about your diagnosis, but really about your treatment journey? What was it that you were expecting and what was the reality?
Sure, and I wanted to start my comments. Michael reminded me of the great quote by the late First Lady Rosalind Carter, that there are 4 types of people in our lives, that we've either been caregivers, we're currently caregivers, we will be caregivers, or we will need a caregiver. And I would have never guessed in a million years that I would have been diagnosed with breast cancer, and not only breast cancer, but triple negative breast cancer a little over 10 years ago. Didn't know what triple negative breast cancer was, but I would quickly find out that it was an aggressive form and a rare form of breast cancer. Fortunately, at the time, I was living in Seattle, and I did have good insurance, and I was able to get access to a clinical trial, and that started my journey pretty quickly. The best advice that I felt like I got early on was from the initial physician that diagnosed me was find an advocate in your oncologist, because the medicine, for the most part, for me at that stage was going to be pretty much the same because I was in a clinical trial. Um, but I have to tell you, it's, as you all know, a laborious process. I was asked to put my career, which I love, on pause, to focus solely on my health journey. And fortunately, at the time, I was married and could do that. But you can imagine for other individuals who didn't have that luxury, how difficult that might be. So I was able to dedicate my full time and attention to the weekly treatment process. What I was fascinated by, Kamal, was because my background is human-centered design. And maybe this was a disassociation on my part, I was so fascinated to be thrown into this system of the health industry that I was unfamiliar with. And how, even though I was encountering dedicated and committed professionals, I was running up against roadblocks time and time again as it related to the system in many forms and fashions. And it was frustrating not only for the care providers, but it was, as you can imagine, it impacted their ability to provide the best and optimal care for myself.
Yeah. Were there specific things that you found to make this treatment path challenging for you? Whether it was, setting expectations, this idea of this is how long you're going to get treatment for, and then, it's going to be over. And was that endpoint really there? Did it change over time? Or was it, the more quotidian things of, now I got to take time off from work. I got to find someone who's going to drive me to and from the clinic. If you had children, do I have to worry about childcare? How am I going to find the time? How am I going to find the money to pay for all the costs on my end? What was it for you that you found the most challenging as you tried to go through this journey?
I think many of the things that you highlighted, certainly the support system is so important. And as I talk to clinicians time and time again and remind them, your interface with that individual, that patient, may be the best thing that they experience the week that they're going into treatment. Because when they go home, we don't really know what that home environment is like. And for me, I was fortunate at the time, I did have a strong support system that dwindled as my treatment continued, because it was unknown. Because I was in a clinical trial, I had sort of a time set for 8 treatments that continued on for 8 more treatments. And because they were monitoring how I was responding to those treatments, the end was never really known. And as you can imagine, if you're in a relationship that might already be on shaky ground, which I was unaware of, but apparently it was, can fracture. And the statistics bear, witness to that 60% of people who go through a critical illness end at the end of their treatment, which you can imagine have not only career implications, financial implications, but a whole emotional implications. And in my case, it did. I had to relocate. I had to rely on extended family to get back on my feet. My surgeries didn't occur until after I had gone through treatment. So I had 7 surgeries post treatment. So you can imagine all the care and support. And fortunately, I had friends and family who stood up and stepped up to help me get through those critical periods of time. But that's on the support end. On the clinical side, there are, a bunch of things technologically and clinically that I think were interesting, just in terms of our dependence on technology, like electronic medical records, which I thought put a barrier between myself and the provider. There were things that had been done to the surgical process that was clearly a Six Sigma process to create efficiency, but made it from a patient perspective feel very inhumane. So there are things that procedurally, I think the system was trying to improve and expedite, but from a patient perspective, it felt very cold and callous, if that makes sense.
Yeah, absolutely. And I'm so sorry to hear about your relationship. This idea that for people who are facing a serious diagnosis like this, 60% of them will see that their relationship comes to an end because of that diagnosis, and they lose the support. They may have to relocate, find a new home in the middle of getting treatment. Yeah, that's a really astonishing statistic to me. And just, really remarkable that you were able to find the support you needed from friends and family. But to get through 7 surgeries, not having that same partner next to you, right? It must have created so much additional frustration, additional work, and additional thought that you had to put in so that you could actually get the care that you needed. And just to sort of continue on this theme, Risa, I know that you have counseled many patients who have faced difficult illnesses. I would love for you to tell us a little bit about, your reflections of your time in practice and, patient stories that you have heard that maybe can sort of illustrate to people why, for patients who really do want to adhere to treatment, challenges like this can come up in their lives that they don't anticipate.
Sure, thank you. And thanks, Kelly, for sharing your story. Um, you know, we were talking earlier that, and even the title of this webinar being about adherence, in the medical system, we used to call patients who were not sticking to the prescribed treatment as non-compliant. And then we moved to non-adherence, as if somehow that term is very different than compliance. It's perhaps a little bit gentler in its connotation, but it still really centers on this idea that the treatment is right and the patient is somehow failing, right? The patient's failing to comply, the patient's failing to adhere. That something is, wrong on the patient side, but right on the side of the treatment. And it's not the health provider's fault, it's not the health system's fault, and certainly not the treatment fault if the treatment doesn't have the expected outcomes. It's that, the patient somehow failed to take full advantage of the treatment. And so I think as we're moving more into this conversation about being patient-centered here in the design, not only of interventions, but of the healthcare system and the workflow around it, as Kelly points out, there were aspects there where, with the way that the EHR was used in her care, that really kind of took her out from being the center of the experience, that we really need to think about this as treatment engagement. And when we think about treatment engagement rather than adherence, the connotation right away sort of switches, where, it becomes this question of, is the treatment itself engaging and engageable, rather than, is this somehow a problem of the patients? And thinking about that throughout the workflow. And I think that's been the pieces I've most seen. A lot of the work that I did, both research and clinically, was embedded in primary care behavioral health. And we would very, very often see patients who, were post-surgical for chronic disease and then were, put back into the care of their primary care provider, who, weren't coming to their follow-up appointments, either with their primary care provider or with their surgeons or with their oncologists, or, kind of fallen out of the system. And those patients were often, at first in the system seen as somehow just being disinterested in their care, or, not properly motivated for their care. And sometimes along the way, we eventually in the behavioral health team said, like, give us a list of those patients that you've lost. And let us try to directly outreach to them and see what we can do to kind of pull them back in. And a lot of those conversations became about some of the aspects that Kelly's talking about, which were just plain functional, right? Like, we have one car in my entire extended family. We live off a bus line, can't get to the hospital in any other way but the car. And my son is the only person in our extended household bringing in income. He needs a car for work. So I just simply cannot get to treatment, right? Questions that were answerable through our system, where we were able to send a ride to them, but where patients weren't aware of that, and where the system itself just assumed somehow this was like a failing of the patient to engage, as opposed to us having this very real structural barrier where they couldn't make it in. And then I think there was these other cases, that it sounds like Michael has some examples of as well, where sometimes it's patient choice of balancing out. Is this a treatment that I want to have this lifestyle of engaging in for the rest of my life and what that looks like? Or have I reached a point where I don't want to be doing this? I saw that most actually with my mother, who's a breast cancer survivor. She's still here and doing great in her 80s, but was diagnosed late in life in her mid to late 70s. And her oncologist was very clear that the proper course of treatment for her type of cancer post immediate treatment was tamoxifen. And her learning about what her experience on that medication might be like as someone who already had a lot of daily aches and pains at her age, and her choice to say, like, that's not what I want for this next decade or so of my life, and her choice to not take that treatment and still be seen as someone who cared about her life, who cared about engaging in care, who wanted the best treatment possible, and not sort of be written off by the system as like a non-compliant patient. So it's like really centering around what is best for your patient at that time and letting them guide that journey, in the way that's best for their life.
Yeah. And, I think your mother's story is so powerful because she sounds like somebody who had gone through so much treatment already, clearly did not want the cancer to come back. And tamoxifen was the best treatment to keep the cancer at bay. And that benefit could be, just a couple of percent in terms of reducing the risk of recurrence. And so what does that mean to someone who's facing taking that pill every day? What does that mean to someone who's facing the potential for side effects? And is that really a worthy trade-off? Sometimes, some providers will sort of say, well, this is the standard of care. This is the treatment. Either you do it or you're not following the rules. You're not following the guidelines. And so I'm glad to see that your mom was able to have that conversation, that her provider was open and engaged, that they talked through those risks and benefits, and they made a decision that was right for your mom. And she felt plugged in enough that she was like, okay, I'm still going to go to my appointments. I'm still going to do my follow-ups. Just because I made this choice that felt right for me, that doesn't mean that I'm not going to continue to get the care that I need. So it sounds like a really, positive outcome in terms of her being able to advocate for herself and having providers who were able to really hear her and engage with her in a way that made sense. Michael, you had mentioned that your father had dialysis. And, so far we've been having conversations maybe more focused on the experience for cancer patients. But, in cancer, sometimes there's an endpoint in sight. And with other chronic diseases, for example, kidney disease, where people need to get dialysis, that endpoint can be a lot fuzzier. It can be a lot farther in the distance. And so, I'd love to sort of hear your reflections, not only from the patients you've cared for, but also seeing your father go through this, about what it's like for somebody who has a kidney disease that requires dialysis to face this idea of continuing to engage.
Sure. Thank you all for sharing your stories and your insights. There are certainly things that cause for reflection. And in the case of my dad, all of the comments that Risa and Kelly have made have rang true. So my dad was a multi-complex patient, as we call it. He had not just chronic kidney disease, he had diabetes, he had congestive heart failure, which was severe from a young age, a relatively young age. So there was never a point in my adult life where my father wasn't sick. And he was a very learned man, he was a very educated man. But the day he became a kidney patient, I really came to the stark realization that there was never going to be a point in time when my dad wasn't a kidney patient. Because whether he was healthy enough for a transplant or dialysis is indefinite, right? He wasn't going to have a point in his life where he wasn't going to need to be on some kind of therapy every day or every other day. So, with him, dealing with somebody who's gone through that much schooling and you have an emotional connection to as a child, watching him go through the fear and the loss of agency was dramatic. Here's my hero. This is the strongest man I've ever known. And all of a sudden, he's feeling very detached from his caregivers because he wasn't getting the education he felt he needed about his condition and his options. And, I think I brought this into my practice quite a bit, is I would always tell patients two things. Number one, I have many patients. Your family has one you. right? And we are here to make decisions based on what's best for you, based on your motivations and your goals. And where I feel you have options, I'm going to give you all the options. And you may choose something that I wouldn't choose, and that was maybe my dad's choice. But where I think you have the opportunity to make that choice without taking what I would consider an unreasonable risk, I'm going to be right there with you, right? We're going to do that. We're going to make that decision. We're going to cross that bridge together. You'll never be alone in this. And I think that really helps patients to feel not only that I see you and I hear you, but I respect your opinion. Okay, I may have more medical knowledge, but I don't know as much about you as you know about you. So that building of a bond, the building of a partnership, and sure, over time, there's pill burden. 42% of Americans have 2 chronic conditions. Most dialysis patients are taking upwards of 10 medications just for various conditions, either directly attributable to their kidneys or their comorbidities. It gets tiring. My own dad was tired of taking his diabetes medication. He was tired of his diet being so restricted from his heart disease, from his kidney disease, from his diabetes. He was just tired of having to make that choice to be disciplined every day. So in the twist of irony that presented itself in my career, I took a lot of what I learned there, and it really, I don't want to suggest that I didn't have that perspective before, but when it becomes personal, you just double down on that commitment to the patient-centered approach, right? Because the only way you're going to have true alignment and engagement and ultimately patient empowerment is to have that connection, right? There are upwards of 24 studies that show outcomes in various aspects of dialysis care, where the metrics are so much better in patients who are engaged with their care team, engaged with the decision making and the care plan. It leads to better outcomes. Yet not every patient feels that attached to their care team. So that's one of the things that we at DaVita are always trying to improve upon. And I think it starts upstream. We have Kidney Smart, which is a community-based kidney education program that anybody can go to. It's free of charge, and this is meant more towards the patients who either have just found out they have kidney disease or are concerned that they might have kidney disease, and anybody can do that. And then once they establish late-stage disease, once you get into a dialysis clinic, it's very easy to be lost in the shuffle of the efficiency. And we have been rolling out new things like DaVita Listens, which is a two-way platform for communication with their care team. And while you'd think there would be problems and concerns voiced through that, there's also a lot of praise voiced through that. So there's a lot of two-way interaction with patients, and they feel so empowered. And then ultimately, the care plan that happens not just with a nephrologist, but with our dietitians, our social workers, our nurses, the interdisciplinary team is supposed to have that meeting with both stable and unstable patients around the goals of care. And to me, I always double down on that. What is your goal outside of dialysis? Because dialysis should not be about having a treatment, recovering, and coming back. For somebody, it might be being with their grandchildren. Others, it's, I got a new boyfriend, I'm going to the casino every weekend, right? It's living life. And I think patients really respond to your interest as in their goals, in their personal life, within reason, of course. So I think I owe a lot of that to my dad.
Yeah, absolutely. And, it sounds like that educational piece is also so critical in terms of making sure that people have an understanding of, not only why the treatment is important for them, but engaging about what it can allow them to do, what about their life they're going to be able to live better because this treatment is going to help them get to those goals that they can set individually with their providers. Kelly, you had mentioned that you were on a clinical trial and that you felt that really helped you engage better. So, as we think about how, some patients may have issues engaging or, maybe trying to find ways to stay on top of, all the requirements that the healthcare system puts on them to be able to complete a treatment. It sounded like being in a clinical trial was really helpful for you from an engagement perspective. So as we think about ways to build better engagement with patients, what reflections do you have about what actually worked about that for you and how we can think about generalizing those principles more broadly?
And I appreciate Risa and Michael illuminating what I think is the core message. What I would want to emphasize here is that we're taking a very human experience and over mechanizing it. And Michael and Risa are doing an exceptional job of making sure that we're focusing the humane part of it. I'm all about technology. I've spent my entire career in technology and love how technology can create those human moments. And we can talk more about that, Kamal. But back to your question. What the clinical trial, as bad as that is to be offered, the only option we have for you is a clinical trial. What it did afford is much more of the human part of the equation because I had more eyes on me. I had more interest in me. I had more time with my physicians and a heck of a lot more of people interested in my outcomes. So for me, I felt like I was getting a little bit more care and attention, which goes back to Michael and Reese's points, was that I sort of was in a different class of a different cohort, I guess, is the best way to describe it. And the type of, and many of you may on the call be familiar with the I-SPY trial. It was the first of its kind at the time. It was based on genomic testing, so that if I wasn't responding to the medicine I was on, I could be taken off of it and put on a different cocktail, if you will. So there was a lot of interest in me. So I think that that underscores the point of this is a human experience. This is not a technical experience. And I recognize that early on. And again, every patient is going to be different. I recognized I was getting exceptional care and I was going to leave the medicine to the medical providers and I was going to focus on, my relationship with my spiritual guide and let the rest sort of take care of itself. And I recognize that there's other patients who really want to get in the weeds with the medical and the medicine and all of that kind of stuff. But I do think that it really underscored for me what I know to be true in the work I do with other industries, that technology is good if it's, as I mentioned to you all when we talked earlier, is invisible. And in my world of human-centered design, there's a famous quote that says, simple is hard, easy is harder, invisible is hardest. And I don't think in the health industry and a lot of industries, we are quite at that point where the technology that we're introducing into this system to support patients and to support the providers that are there to help them is invisible. And it's my hope and desire that we get there so that we're back to this human experience where I have a regular interface with Kamal, because I do think that that generates better health outcomes.
Yeah, absolutely. I think it would be great for us to talk a little bit about sort of where things are shifting. But before we get to that conversation, just going back to what you were reflecting about being on that clinical trial and how you felt like people were really paying attention. People were following up with you, people were asking you questions. It felt like the team that you were working with was highly invested in your care and helping you make sure that you were getting the best possible outcomes. And so I guess, Risa and Michael, I would love to hear from you in your practice. What are the ways that you found to be able to engage patients in a similar way? What are the things that we as providers can do to help patients realize that they are at the center of this treatment? Kelly had mentioned that there were parts of her treatment journey where she felt like, things were just kind of, there wasn't a human touch. People were just kind of proceeding quickly to be efficient and to get things done, as opposed to engaging her directly, and that those two experiences seem juxtaposed to one another. So in your clinical experience, what are the ways that you guys have tried to incorporate this idea of helping the patient realize that they really are at the center of their care and helping them feel engaged so that they do feel like, oh yeah, I do want to actively participate. I do want to keep coming back. People are really thinking about me and what my needs are.
Thank you. I can think of a number of different ways to come at this question. And one is, from my experience running clinical trials, that, probably, Kelly, a lot of the attention you got during that time was not necessarily from the medical team or the PI on the study. I'm sure there was more of that than you might have had otherwise, but you probably also had a lot more eyes on you and attention from, study coordinators and, the research coordinators and the folks who are interested in your data and interested in whether or not you were showing up for your treatments, or, and kind of tracking you and reminding you of when the next intervention would be. And I think that's a piece that we can all learn from. Right? We talk a lot about provider shortage and staffing issues and how difficult it is to, have more provider attention per patient, even for really chronically ill patients. But a lot of that support when you're in a clinical trial is not from the super highly trained, super expensive medical team. It's from the, paraprofessionals working in that area who are, reaching out, who are engaging with patients, who are forming that relationship. I know in a lot of our clinical trials, the strongest bond was between our patients and their, bachelor's level research assistant who spoke to them every week, rather than between the patient and the clinician. And so I think thinking of models outside clinical trials where we can staff up that support, around other humans that are in the workforce, that aren't, peer support, other, lower level providers, rather than kind of thinking, well, we have a provider shortage, we can't possibly provide that kind of attention. I think the other piece, and I'll let Michael address this one first, the human side, but, I am really interested in Kelly's thoughts on technology, because a lot of the work I do now is on building tech and thinking about, as we're building these digital interventions, how do we build them hand in hand with our patients? How are we doing patient-centered design on treatments that we're building? And it's trickier in my space, which tends to be a little bit more on the mental health or behavioral health space, outside of, maybe note taking, to be completely invisible. And so what does that look like? I'd love to hear more from Kelly of like what that looks like to build something that's truly engaging to a patient, that when it's not 100% human. And how do we think about where we keep humans in the loop, even when some of the intervention is digital?
Yeah, I think those are great questions, and I'm super excited to hear Kelly's thoughts on that. I just want to give Michael a chance to sort of give us his experience in terms of how do we think about additional providers on the team or staff members who may be involved, and how they can help keep patients engaged and keep them coming back and feel like they're at the center of their care.
Yeah, and I think it's really important to consider that right now, at this moment in time, we've seen in the last 5 years immense turnover in healthcare, right? So compared to before the pandemic, there are so many people working in healthcare now that weren't working in healthcare before. So we have a lot of folks who are coming into this, bright-eyed, idealistic, and ready to go, but we need to help make sure that they're maintaining a level of consistency. So I think to get them more engaged, to get more of a patient-centered approach, I think there's a lot of things that have to happen. And I think it starts with how we address a care plan. So when the team meets, for instance, for a dialysis patient, and everybody is weighing in, whether it's the nurse, the tech, the social worker, et cetera, we're coming up with a combined multidisciplinary care plan. And where that has its underpinnings is we have our software platform interview is called CWOW, Center Without Walls. And that's a big shift, because 15 years ago, the data was all clinic centric. A patient goes to clinic A, your data is in that clinic. Center Without Walls makes their data available, their prescription available, their labs available to any DaVita clinic. And we're not going to stop there. We're going to keep expanding and connecting, because the more connections we can make and the less we can silo the information, the better the patient experience will be. Beyond that, simplifying the care plan. These patients have very complex problems with very complex care plans at times, and to the degree possible, simplifying it for them. And one little trick that I used to use in my patients directly was I would always go that little extra step to make sure that I spoke to their other major consultants, their diabetes specialists, their congestive heart failure specialists, so that the patient doesn't have to be the one communicating with each person. Because going into the medical record right now, there's so many notes from so many people. Let me just make sure these people are looped in, and the patient can rest assured that their team is communicating so that they don't have to be the conduit.
I imagine that makes such a huge difference when you're having a conversation with the patient. If you show up and you're prepared and you know the conversation that they've had with their diabetes specialist or their cardiologist, it sort of shows that extra level of care. I really have been keeping tabs on what's going on. I really am invested in your care. Here I am showing up. I've had those conversations and I'm ready to integrate that with the care plan we're making today for your dialysis.
Yeah, and I think where technology can really help us is also to identify the more vulnerable patients who maybe are struggling. Sometimes it's not obvious, especially in dialysis. We have the privilege of seeing patients in hemodialysis 3 times a week. If they're doing home dialysis, usually twice a month. That's still a lot more than they see some other medical providers. So that privilege comes with some responsibility, right? So we have the ability to connect with these people, and quite frequently they see us as their primary caregivers because we see them more often.
Yeah, absolutely. And just so important to think about all of the different people who touch that patient experience, whether it's the people who are working on the clinical trial or an advocate who's there with the patient or, the different members of the care team. Really important to think about, how does this integrated whole focus back on the patient and provide that patient with that experience of feeling cared for and feeling engaged with their care. I mentioned at the top a little bit about care navigation, but this is another place where people are thinking about how do we reach out to people who are not necessarily on that initial primary care team, but can provide some help to the patient, whether that is, a buddy who's going to go with them to the appointment and be a second set of ears and take some notes, whether that is someone who's going to help them make that next appointment or find that, specialist that they need. Care navigators can really play a role in helping patients feel supported and helping them feel at the center of their care. Care navigation services are now covered by most major insurances, also covered by Medicare and Medicaid. This was a lot of work that was done during the previous administration to try to make sure that, patients don't feel alone in this care journey, and that they have that support that they need. Kelly, you've touched a little bit on your experience in terms of technology and how, having that EHR there and having your care providers, sitting there typing notes instead of facing you directly and engaging you in conversation, how that can really affect how engaged you feel in your care. So I'd love to hear a little bit about, a specific experience you had that really stuck out to you. And then also, based on your expertise, you mentioned that integrating technology seamlessly should really be the goal. What your thoughts are about ways that we can start to think about integrating, whether it's AI or other new tools that are coming out to make that experience better for somebody who's going through it as a patient.
Yeah, so the electronic medical records, I hope that we've made some inroads there. And I imagine my providers on the call here probably are happy with that as well. I'm now taking care of, much like Risa, taking care of my mother. And so I attend doctor's visits with her, and I've been happy to see the integration of AI on iPhones that can dictate the office visit. So it's all that electronic medical records, it feels like to me, has been packaged into an AI application so that that can be dictated, and it puts the provider and the patient more in the intimate face-to-face setting. And I can tell you that it makes my mother and her daughter feel very much more, cared for. So I think that's certainly a way that it can be invisible and much more patient focused. I mentioned briefly when we started the call that because of my background in consulting, it was clear to me that the institute where I was getting care had used Six Sigma consultants to expedite the surgical process. And I totally get that we're in a stage where we need to cut costs and be efficient, but it felt more like a cattle call. And particularly when you are getting a sensitive surgery, like putting your port in to have your chemo put in, or gosh forbid, your mastectomy. I literally, because of the care and attention of my breast surgeon, I don't kid you, she pulled me up out of my surgical cubicle and took me to the employee snack room to make her surgical drawings so that I would have some degree of privacy, because they had made this, where I could be next door to my boss, my ex-partner, my next door neighbor. So hopefully we've made inroads in that regard. Kamal, you might be able to help me with that. But I also am an advisor for MIT Hacking Medicine, which many of you on this call probably are familiar with. And these bright minds from diverse industries come together annually and are really coming up with amazing ideas on the integration of technology and how we can do it in a way that is less intrusive for patients and more empowering for the providers. And it can only be helpful for the systems and for better business outcomes. So, one that comes to mind is using the iPhone to look at retina. And your retina tells you all sorts of things about your just general health. And all of that can get uploaded to the cloud and tells you all sorts of information. Kind of back to my triple negative breast cancer, I had mentioned this to the team when we had talked earlier, that Anil Sethi out of Apple Health was dealing with a sister who was going through triple negative. She was in a clinical trial. She was seeing all sorts of specialists. Every time she went to a physician, she was having to move her data between these multiple specialists. He was so frustrated as someone who worked at Apple Health. He said, we have the technology that she shouldn't have to, going through a critical illness, have to pack and move her data. And so he stood up Citizen, which just in the last few years was purchased by, I'm not going to remember who purchased them, but for like $350 million. So there are ways that we can create technology that may not be entirely invisible, Risa, but getting darn near close, so that patients like myself, when I went through my experience, I just wanted to focus on, you know, rest, care, and all of that other stuff, and let you all drive. By you all, I mean Kamal, Michael, Risa, all the providers, and that I could just focus on, kind of riding the train. And my hope is that we can get to that.
A lot of really thoughtful points that you brought up, a lot of, rich experience that you've really had from both the patient perspective and then, the expertise and innovation that you bring, that lens that you bring. It's really interesting to hear, your thoughts on AI scribes, where now, as you mentioned, someone can walk in the room with the phone and the phone can listen and transcribe that visit. So now the doctor doesn't have to sit there and type the notes. It's all being done ambiently in the background, powered by AI. And hopefully this will improve, the experience for patients so they don't go through what you went through, where you felt like you couldn't engage with your provider. They weren't really listening to you. They weren't really as focused on you and your story and your care. So I think this is a great example of technology that now is being rolled out more widely across the healthcare community that hopefully will improve that patient experience. It's also interesting to think about, patient-centered design more broadly. And, if we are going to expedite the number of surgeries because we don't want patients waiting, we do want them to get in. How do we make sure we do that in a way where the patient still feels like, they still get that humanistic touch that medicine, is really about? Just so many rich, interesting points, that you brought up there. And, Risa, I'm really interested to hear more about your work and how you're thinking about incorporating not only technology and AI, but patient-centered design in advancing the care of the patients you take care of.
Sure, thank you. one of the things that always comes to mind when I think about these AI scribes in general, but then in this particular conversation, hearing Kelly sort of juxtapose that conversation about the, ambient note takers with your experience with the Six Sigma process in surgery is just this piece of, for me, like a cautionary tale, right? Which is that as much as I think that has been one of the best uses of AI and technology in healthcare. There's this danger that it's also used to make sure that the provider can pack more patients in, right? Because if the provider has less time that they need for note taking, if you're in a Six Sigma process, that means like them are going to just pack more patients in. And so part of the beauty of these AI scribes, for the patient, is potentially that more attention and more, feeling like you're being cared for by your provider. And for the providers, doing the work that they tend to most care about, right? Very few providers go into this kind of work for the administrative pieces. And so hopefully some of it leads in the right systems to more attention, individual attention to the patients that they do have. And not only, I'm sure, there'll be a little bit more patients, but not only to like stacking them in, right? Because I think that's like, for me, that's always the piece that I worry about being kind of the flip side of those AI scribe coins. That I think for us in terms of, go ahead, Kelly.
I was going to kind of just dovetail on that there is a cognitive connection to scribing, like personally scribing too. So I think that you make a very important point. I know with my graduate students, I encourage them to get away from their devices and their technology and actually scribe notes, because it's important for us not to lose that cognitive ability. So that's another thing. I mean, I talk about AI ethics all the time. So Risa, you bring an important point, especially, and we talked a little bit about this offline, is that things I am hearing from clinicians are the new influx of young professionals coming in and their loss of empathy and their loss of compassion, and some of these things that we're talking about that are so vital and so important to the patient experience and the patient outcome. So how do we balance the need for these technical applications and also making sure that we're keeping, humanity and the humanness in it? So
Such an important point, really important question. Risa, I don't know if you wanted to speak on that a little bit more, or, Michael, if you want to tell us a little bit about how you've seen technology being used to actually focus and center the patient when it comes to people who are going through dialysis.
Yeah, so as I mentioned before, our clinical platform is Center Without Walls. We have a lot of back-end innovations that are not very visible to the patient, but visible to the team, take the shape of, for instance, alerts that say, hey, this patient has had this setting on their dialysis treatment for X amount of time. And it gives the provider at the chair side some context onto that particular patient's physiology and how they've responded to therapy. So on the back end, on the team side, I think that is much more personalized than a one-size-fits-all prescription. As far as engaging the patients, we have a lot of energy devoted to, or at least I have a lot of energy devoted to motivational interviewing, right? So when I went to medical school, I was taught how to interview a patient, take a medical history. And for years, I took the history the same way. And then once I heard about motivational interviewing, I thought, oh, yes, I've open-ended questions. Yes, I've done this in medical school, since medical school. And then I started reading about it. I'm like, oh my gosh, why did I never know this? I was not aware that this existed. But I realized that it was a name that I could put to a style of interviewing I had used for years. And as I mentioned before, we have a lot of new people working in healthcare. I feel like shifting that focus of how they engage the patient, on a face-to-face basis, makes for better conversation and better engagement, such that the patient can then feel comfortable asking questions, get the answers they want, and then apply both their goals to the prescription and vice versa. And that way we have more partnership with the prescription. And I think you see it pretty clearly in the literature. When the patient understands the why of the treatment, it tends to result in better decision making. So I think that's what we're all striving for, because
I
every
love that you
decision they
brought
make
up.
matters to them. It makes sense to them, right? That's what I always tell my students is, the patient makes a decision. Maybe you don't understand why they're making the decision, but it makes sense to them. So let's give them the context, the background, the knowledge, and the why, because reasonable people want to be reasonable.
Yeah. And Risa,
This is,
I'm interested to hear, your perspective on this as well.
yeah, I love that you brought up motivational interviewing, because we had one of the questions that was in the Q&A. I think that's sort of the primary answer to in my mind, right? So one of the questions was, how do we create space for patients to share that they're struggling to be engaged with the treatment without fear of judgment? And I think that is the answer, right? Is that motivational stance where you're meeting your patients right away with, as you're explaining the treatment, with the stance of, we know that there are going to be things about this that are positive for you and that you want, and also things about this that are going to be negative. And what are those negative things? And asking every patient that right away, because any treatment comes with some loss. Certainly dialysis does, right? There's a big loss of time for patients, and other roles that they would be filling in those times, right? And so being able to right out acknowledge at the very beginning, like when you're hearing about this treatment, what are the things about it that feel like a loss and not a win for you, and being able to let patients express both ends of that so that they can come to their own decision about what it is they want to do.
Yeah,
And
absolutely.
Rita,
And
I see there's a question in the Q&A about health literacy, and I think that kind of dovetails into kind of my comment and Risa's comment here about what role does health literacy play. I think that's a great question. You have to meet patients where they are. And one of the challenges that I gladly accept as I design initiatives for the field, or I help design initiatives for the field, is having multiple different styles of communication at multiple different levels meant for different levels of education, and language barriers, right? Such that we can overcome to get a level playing field for patient understanding. So getting them to truly understand isn't just, giving the same style of education in the same way every time. It's trying to figure out what, I'll be the first to admit, I'm a very visual learner. You could tell it to me 5 times, but show it to me once and I get it. So thank you for the question.
Yeah, and kind of to dovetail on Michael and Risa's points, for those on the call that aren't familiar with the Picker Institute and Harvard Medical School's work around the 8 principles of patient-centered design, I imagine many of you are, but because I can't remember 8 principles, I roll it up to 3. So it's really about, and Michael and Risa and Kamal have all touched on this, but it's really about respect and responsiveness, coordination and communication, and engagement and empowerment. And where a patient falls on each of those is going to differ depending on them. And that's very much about human-centered design. Human-centered design is about what's technologically available, what does the marketplace demand, and what does the user need and want. And oftentimes when I work with other industries, they're all about the technology in the marketplace, but they leave the users out. And I think the health system does the same thing. So if we can make sure that we always go back to the Picker Institute work on those 8 principles, or as I like to do, kind of whittle it down to those 3 core, and think about whatever we're doing, is it within the bounds of those, knowing that every patient's story is going to be different. Every patient's story is going to be different. It's not a one size fits all, as I think Michael had talked about earlier.
yeah, absolutely. And, we've only got just a few minutes left here. And so, I just wanted to invite our panelists, if you have any parting thoughts, I think we've had a really great discussion about ways that we can think about being more patient-centered, whether that's through patient-centered design, whether that's thinking through what the barriers to adherence could be, meeting patients where they are, making sure that they are well educated and can make decisions that really resonate with, their priorities and who they are. I guess to close things out, what are the ways that we can make sure that we continue to center the patient as we try to provide the best care possible?
I think,
I could start.
the-
Oh, sorry, go ahead, Rachel.
I was going to say quickly, I think building, whether you're building a technology or whether you're building a workflow, but building with patients in that build process is essential, right? We too often think we know sort of what's best and how it's going to work for them. But if what you're building, whether it's, in a digital intervention or just in coming to your, physical clinic every day, is a patient journey, you need the patient there during that build to help guide that journey. I don't see how you can truly be patient-centric unless you're building together with patients. And I think we're seeing more and more, patient panels and advisory boards at larger companies, but sometimes that's a checkbox and not always truly engaging patients in the process of building your systems. And so I think the more we can do that, the more we can move to really center on the patient experience.
That's great advice. Yeah. Michael, what are your thoughts?
Yeah, I mean, I think keeping this patient at the center of the process is obviously the most important. Considering how patients move through that journey, that's very burdensome. I think Risa said it best, that going to dialysis is like having a part-time job. They don't have time for other appointments. It gets in the way of their lives. I think where I come down on it is needing to be reliable and accountable consistently over time as a system, as a healthcare system, right? Because these patients, their stresses in their lives may vary, but we may be the constant, right? And if we are the constant in a positive way, that makes a difference for people, right? So to me, that's where my primary North Star is, if you will, is to be consistent, accountable, and reliable. I think as we move forward, I think the idea of invisible AI or invisible technology, it's aspirational, of course. It's the end of the rainbow, so to speak, but it is what we are striving for, right? So I don't need it to be intrusive. I need it to be helpful. And with that, I'd say, there are a lot of things we didn't touch on this call, which, is unfortunate, but it's a broad topic. I think going forward, understanding where, not just the technology and the patient fit into it, but how we can upskill the community, right? Because there are so many people living with kidney disease who don't know it, and we can't help the people who aren't here, who don't know they have the problem. So screening is important. And then once you're in the system known to have disease, it's how do we ensure that you're engaged and disciplined and motivated enough to follow through and meet us, for what we feel you need, and we take that journey together. So I always tell patients, I can't help you if you're not here, right?
Yeah.
So.
Absolutely. And, to Risa's point, engaging with patients from the very beginning, as you think about how you build that system out, how you build those tools out to take care of patients, really critical, because unless the patients are in the room, they can't tell you what may or may not work for them. And Kelly, any final thoughts from you?
Yeah, and thank you again, Kamal, and my panelists and Davita for hosting this. I'm going to borrow from Dr. Singh, who has said, sometimes or most of the time, we're so focused on building the bridge and less concerned about the people who have to cross it.
Yeah.
That's probably not an exact quote, but that sort of summarizes human-centered design. We get so excited about the technology or the equipment and I would encourage people who are listening to check out Doug Dietz' story from GE Healthcare and how he revolutionized the MRI equipment because he went out to Stanford Design School and realized that, oh my gosh, if I include multiple people looking at a complex problem, we can reimagine the patient experience. It's a great story. It's an inspiring story and underscores our conversation that we had today. So thank you, Kamal, for a great discussion, and my colleagues, Michael and Risa, I appreciate it. And to our host, I appreciate it so much.
Great. Thank you all so much for joining us. And thank you to those who tuned in for the webinar. We're super excited to be here to talk about patient engagement, and hopefully this is just the beginning of what will be many follow-up conversations. Take care, everybody.
Thank you to DaVita and everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Join us in Los Angeles, February 22nd to 25th for VIVE.